All right. All right, so today we're going to practice the pressure relief and positioning to help our patients maximize their independence and avoid pressure injuries. Pressure injury is the most common complication after a spinal cord injury. Do y'all know where the two most common places are? In the heels. All right, so let's divide into two groups. This is going to be the sideline positioning, and this is going to be supine. I need one volunteer in each bed as a patient, and the others to put all the pillows around them. And then we'll kind of talk about, once y'all are kind of set in position, we'll talk as a group to talk about, where the pillows go and why they're there. All right. Somebody come hop in this bed.
We're relieving pressure, right?
Yep.
All right, we'll start.
So this is, as they say, supine on the spine.
Okay.
Tony said that a lot this morning. All right, and this is sideline. So you've got pillows next to you, wedges. Let's just start kind of putting pillows where you think they belong, and we'll kind of talk about if that's the right spot. And
Which side?
Whichever one you want.
Okay.
You want to roll it out? Well, normally I roll it for you, probably.
Okay, I'll be like a C8.
What's that?
I'll be like a C8 or something.
Oh, God.
Okay, never mind. I'll be a C7.
We have a wedge. Yeah, we have a wedge. I didn't realize we had one. I was about to do it.
all right, so the thing that we want to look at the most in sideline is to make sure that that sacrum is clear.
Right.
So if there is a wound, it's breathable. So sometimes the pillow might be in the way. So lift up your head, and you can always just kind of move the pillow out of the way so that it's behind the back. All right, looking good over here. Now, if she was a quad, you'd want to make sure her hands are more upright to kind of help with edema control.
Okay.
So some patients, they might want one pillow across if they're kind of up a little bit more playing on their phone, or you can maybe put one additional pillow on each side to kind of keep their hands in a better position. All right. I'm going to have you stay here just so they can kind of check out. Y'all did great.
And then we'll go over there.
Uh-huh. No, y'all, we're just going to watch.
Okay.
And then, all right.
Tell her she can't fall asleep. I think they just
So,
set it there.
so sideline is one of the more difficult positions probably to make sure you have everything in the right spot and have the patient comfortable. But it is the position we want our patients in the most around here. They tend to be in their back or sitting on their butts in the wheelchair throughout the day. So especially in the evenings and at night, they need to be on their side, that rotating schedule every 2 hours. So she did a really good thing just now. If y'all saw her shift her weight, some of our patients cannot do that, and they can't get their arm or shoulder out from underneath them. So it would be best if we could, you can kind of go under and scoop, kind of, and pull her forward a little bit to make her a little bit more comfortable. And then with having the wedge back here, if the wedge isn't close enough, you can always add an additional pillow behind her shoulders and then kind of let her rest back a little if she wants. And it is also nice to put a pillow under the arm to help support. The elbow is a very bony little area, and sometimes it's just comfortable to kind of hold on to something like that. It's really good. I'd probably put an additional pillow here just to make sure her hips are in a little bit better alignment. But I like that her knees are staggered and her feet are staggered because you don't want those bones touching each other. All right, so this is sideline. Maria is over here in supine. All right. The key to this is you want to make sure the heels are floating. So you have to have enough pillow under the leg. Sometimes our pillows are flat, and if you put one under there, it's just not enough. You got to put a second one. Or the boots. If there are boots in the bed, their boots need to be on their feet when they're in the bed. All right, and then see how they have extra pillows at the hands just to kind of help elevate the hands for edema if they need to. You feel comfortable?
I'm taking it.
All right, so this is a good deal. If there was a patient in supine and y'all came in to maybe help with a tube feeding or something like that, or they wanted to sit up. Do y'all know how to gauge the angle of the bed? Mm-hmm. So under the bed, on the frame, near the hip area, you have to get down really low, but you can see that there is a degree. So if you start going up with her bed, if you guys can get low enough to see that, you can kind of see it on the frame. Currently you're at 20. So you see how the little arrow just kind of glides? That's 30 right there. All right? And I think Bruce wanted to make sure everybody kind of knew how to find 30 on the bed. All right? Especially for tube feeds.
You look really comfy. The sideline was comfy too. With all the extras. I was like,
All right. Thank you, everybody.
which one?
I'm in the resource room, but I'll just text her.
Hello.
No, we deny a patient of the room that
Okay, so you're gonna take your suppository, you're gonna lean, and you're gonna try to get it as close to your rectum as possible. Because this is like you're inserting your suppository. Remember, you can't use your legs. No standing, your legs do not work. Correct.
Now your urethra is. Is she the only one that can't use her legs or none of them?
No, none of y'all. Y'all are all paralyzed from the waist down.
Give me that. I'm gonna put this piece of tape in there for you.
You got it, Corey?
triceps. I'm triceps. Okay.
I'm something.
Put it way in there where you
So hard.
right
It sticks to the
Yours
ground.
too. It's too high. It needs to go way down.
So at this point, you have to ask your
therapist for help.
So hard to do this.
Selena takes
Like
mine
in
for
like,
full.
I don't know, but stuff your brief under there.
Just take your glove off.
Like,
Like that's that. I mean that's good. That's
You
bad.
need to hold it in the
Alright, so
I'm good
y'all are gonna be getting in these positions. Another one's like butterfly position where you have it like Indian style. One's like one could be like that, you know, just depending on how we can. So these are.
This is your dill stick.
that
Are y'all familiar with this
It
piece
has
of
their
equipment?
water in them, so they're wet, but it's not gonna stain or
Yeah,
anything.
whichever hand's more comfortable. So you take your top off.
These are closed systems, so they,
Okay, so
Can be
you're
thrown
gonna
on the
lean.
floor,
The goal is to get
top can
on
be
the
taken
piece of
off,
tape that
thrown
you
on the
put,
floor,
you're
and
gonna
it can
make
still be used,
a circle
okay?
for
And the
30
reason why is
seconds.
'cause they have
That's
this
like you're
little
doing digital
fancy
stimulation.
tip right here.
So whoever can get the
And all
closest.
this clear stuff is all over on the top
prize.
of the cap.
Can we fill the
So
tape again?
you have,
No.
your body normally has 15 millimeters of bacteria in the urethra.
Because your suppository's already dissolved by now. It's
So
gone.
you can clean out any time that you won't feel and it's still gonna have a little bacteria.
So really, like, I
So
wanna go
there's
underground.
now research that if they made something to bypass that, you don't need any washing, you don't need any of that kind of stuff or whatever. So that's the reason why it is a closed system. So we're gonna take
You're not
it
falling.
like this, alright? And you don't really have any thumbs to work with either because they're still
30
fixed.
seconds.
So you're gonna have to grab this top
I think I'm just not.
and then grab a little, grab your left hand, go down closer. There you go, okay? And I like to put it a
That is
little
a
bit
true
closer.
balance act.
And pop that open, you might get some water
Kelsey's just
splash
shorter,
on
so
you.
she can manage.
Good. Okay, and just drop
I'm
it.
doing a really better job.
After 30 seconds, you can
Alright,
stop.
and I like to put it this way because you
Oh,
can
we
see
supposed to
it
be
better.
counting?
Alright.
I don't know if I did
So
anything.
I like to
Okay,
keep
put
it
your
up
tops
there,
on.
you have
Take
more
your heel
control,
sticks off.
and so
And we're gonna judge
find it.
one at a time.
And that's my stabilization.
So Corey,
And
you
then
come up first, and we're gonna check out his butt.
Grab and just push on through and hold with your thumb.
Wow.
Corey, that was pretty good. You're right on it. Alright, Tier's turn.
So I thought. Y'all are down again.
Turn around, do the turn.
T tries.
My body looks like that.
Alright, Kelsey.
Is there anything?
It's on your butt cheek. Hey, Corey, you won. Good job.
Y'all were down.
Claim your,
Y'all were sitting over here.
claim your turn.
And we are
So you're
going
gonna lean and you're gonna try to
back
get it as close to your
and
rectum as possible.
the-
Here, let me put this so nobody's here.
straight leg, open, push that urethra way down there, cause it's normally not high that far. There you go.
It's like pin the
I still
tail.
did.
On your own self.
Alright,
Okay, so
okay,
now
so
take your
this mirror can wrap around your leg, alright? So you can put that on,
and you're gonna put it on like this,
and we have that mirror, it's self-explanatory.
and then take the top
We
off.
have this mirror right here that goes in between a person's legs. Maybe have it, maybe like so. Yeah, so they have to pull apply.
And so what you're gonna do, you're gonna lean,
So awesome.
and for 30 seconds, you're gonna make a circle, and whoever
Okay.
gets the closest
So,
to where they put their piece of tape.
We have to normally categorize every 4
So
to
for
6
30
hours.
seconds, this
Okay?
is what the patient's
On
doing.
these patients, we have to figure out how much urine they're producing, if we need to scoot it
Whichever
up,
way
or
you
if we
wanna
need to
go.
scoot it back. So we are gonna be using these closed system catheters,
There you go.
and will be, oh, this is mine, so.
I'm not sorry,
You got
you're
yours
watching the
over there?
video.
Okay, so for the purposes of this activity, we're going to use, we're not gonna be able to use our fingers, okay? Do you need a
It
pillow?
makes you realize.
Yeah.
And they have to do this 3 to 4 times.
So artificial timer says like
Yeah. Casey was watching. Alright, so we're gonna check Dawn's butt out first. So let's see.
Look at
Alright,
it.
so like I said, so these, are closed
Yeah.
system catheters,
Very good.
okay, which means that
Alright, Casey.
this is, you can pull it right out of the, this thing
Here's
here.
your marker.
It's got sterile water all the way in the package and
I
inside
would say
this
this-
tubing here, okay?
Yeah.
And it's got a little plastic sleeve on the outside.
It was
This
open,
is
you seen you take the cap
This is
off.
to protect the catheter part
Well,
right now, okay?
I guess I gotta give it to
So,
Dawn.
we can use our thumb,
Did I?
okay, like this,
Well,
and then this, and that's it, okay?
Alright,
So, no
don't
fingers,
claim your prize, Casey, you can also have a prize.
just like,
Okay.
you know, whatever, cause that's,
So,
they
you
can't
can
be
see
doing that.
where
So, this,
you can get whichever.
I'm gonna show y'all this
This
little
is
top,
difficult,
okay?
embarrassing, because
That
I'm
is
sitting
a
here
little
watching
plastic
these
piece
people do
that
this.
goes, that's on the
And
top of it,
it's-
it's about
It's hard,
15
because like I said,
millimeters
you only have
long,
one round, they
which
gotta do
is
it
the
3
part of
times,
your
and you gotta
urethra
wait
that
15
always
minutes
has
in between
bacteria
each
in
round.
it, just the first
So
15
whenever the
millimeters.
patients are at the
So
point where they're
clean as much as you want to, and you
Right.
still don't
So
have
they're
a
doing
little
that,
bacteria
you're
in there.
sitting here, right?
A lot of
So
times
they
it's
stay
fine
in
on the
place
outside,
for
but when we push it in our bladder, that's gonna cause a problem, okay? So, that's what these systems are for. So,
That's why
I
we
like
wanna
to,
use like
been
padded
grabbing it
equipment,
this way.
because you can imagine
Alright,
if
very
you sit
close to
here
the
for 30
end.
minutes, you're gonna have redness.
there you go, so you have a little bit more control.
So we try
And
to use
then,
the padded
been using
equipment.
my thumb
But yeah,
I feel like we
to
bonded in a whole new way.
pull it out, okay?
but y'all did good.
Alright. Okay,
Y'all
and
were
so,
rocking it.
keep it held like this, I'm right-handed, so I'm gonna use my right hand.
It's funny,
But,
because every time I have an OT,
you're gonna
they like literally
Find your
my butthole
urethra
there.
in your
It's like,
your
got
mirror
it.
there. Don't be using them legs.
Y'all get to cap next. Keep your equipment on.
Okay, keep it on.
Yeah.
Can you
Y'all
see
put
it?
your deal sticks back.
Okay.
I'm on mine.
Alright, so we'll put it in the
But you
urethra,
can see where you could help work on
okay, and then you'll use, and keep that one there, you push it in,
all
and
that
then you'll
fun stuff
grab
to help
close
with the
again,
bowel program.
and just
Yeah.
push
There's
it on
tons of
in,
things
and
to
that, your one hand
You know,
at
on
the top
side,
stays.
side to
Oh, yeah.
side.
Tons of stuff you can do.
Okay.
Somebody has, clearly if they're wearing a TMS.
Mine's,
Right.
mine's stuck
They're
out,
not
I
gonna
don't
be,
have
they're not gonna
a
have
lot of.
but they
yeah,
can still
mine.
go like.
Yeah.
So-
You have a bolster.
Yeah.
Sometimes people can't feel anything, you know, and they're definitely not gonna feel in their urethra, so they'll see urine and that thing right there to know they're in the right spot. So these are really cool because you can kind of
So
go
they can get to the.
wherever and mess up and still be.
But yeah, you're gonna have to allow it to lean, like there's.
So
no
there
other
are,
way
these are
around
kind
it.
of flimsy ones.
So,
This one
but yeah,
is
there's
more
some
of a
stuff that you
rigid
can,
one, it's the
that can
same
work on
catheter,
to help with bowel programs, and you just, you don't think about it
but it's
sometimes,
just
but,
long and straight.
cause like
And
when
so
we do
this
the
one
bowel
might be better for
programs,
somebody
like,
that
I'll
only
schedule
has
2
this
hours.
amount of, you know.
So they're doing
things
that,
there.
and then when they come to PT,
If they have
sometimes
fingers,
they're
they'll
tired.
probably
So
be
it's
better
a lot of work,
using
so we'll
this,
try to, like,
like this
split
one right
them,
here, cause they have
like
more,
morning
more,
bowel program and then PT now.
less
so they
injury.
can like focus on.
We also have,
these
Have a little
straight
time
catheters. It is it's exhausting being in there with them.
Yeah.
Because it's like you're
But it-
problem solving a lot.
where's
like,
my other
And
catheter?
it can be very frustrating, like if they can't figure out a
So
certain
this one
position or
is just plain,
how their
okay?
body is. Like
Has a
some
hole
people
there
are.
and then a hole there,
Right, so it's
okay?
one thing.
So
to
this
just
one,
wait on
you'll
time.
need,
You
you'll
know
need
which
to wash
way
your
to go
hands,
and
of
you
course,
just have
when
to
we
wait
get
for
them, last time I
people.
forgot
That's
to
a
say
whole
that.
different
And we'll have to have
stress
lube on the
really
side
trying to figure out
of
just
their
what-
bed,
how's it gonna work.
you know, wherever their supplies are
Yeah,
set up.
That's the
And
frustrating.
we'll have to have a cleaning
And that takes
solution to clean
Get through that, like,
use betadine, use Sunny
to, like,
wipes.
figure out what's gonna work best for
that
that
are allergic.
So then the magic really
And
is
also soap
trying
and
to
water
find the
when they get
balance
home.
between
So,
letting
and
them
then I'll
try
have
it
to take
and
this
not
out of the
letting them
package
get to the point of
and
frustration
just
where
go
it's
straight
just-
into the toilet.
Because they're already
usually.
depressed, because they're paralyzed.
If we ever
so
use
yes.
these here,
Yeah.
we're usually counting their
It's-
urine or
yeah,
whatever,
you have
so
to-
it might go into your, I don't know what they
You gotta
do.
know when to
what
step
those
in and-
actually
and let them
start
succeed.
doing, which,
Even if that
what,
means
what they do, unless we just bladder scan before
I
and
know,
after.
it's lots of,
So, and
lots
tell
of
how
tears
much
and
urine is in.
things.
So, the OT saying that it usually takes about an hour to help somebody do a catheter, okay? That's not us doing it, you know, in there. And us nurses, we have a lot of patients, y'all have a lot of patients too, but you can't spend an hour with one person when you have 8 patients. So, a lot of times the patients, we try to carry over you guys' education, you know, into our nursing floor. So, a lot of times we get, I'm so tired, my arms are just so tired today. I've already done it, it took me an hour and a half, you know. And so they'll say, I don't wanna do it, can you please do it? And we end up, you know, pretty much doing it. So, exit interviews, from what I understand, is that some people are wishing they had more chances to use the catheter system before they discharge. So, we're kind of lacking on that area, so we're gonna try to start implementing on the floor where we as the nurses are gonna go in there and do exactly what the OTs do. We're not gonna do it for them, they're gonna tell us what they need to do, and we're gonna help where they need help at, okay? So, we'll have to have a lot less patients when we do that, because we'll have to do it 3 hours a day, we'll be in that patient's room. Okay, so if we try to do it as much as possible, I mean, that every 4 hours is a lot, that's 6 times a day that we can actually have education on these patients. So if we did that for like a week, they should definitely, you know, figure it out. So hopefully, once we all check off the patients, and they're good to go, our CNAs will go in there and help them position, if they need help position, they get their supplies or whatever. And then they'll let us know how much urine is coming out of the patient, or when to come back in and bladder scan. So, we're hoping to start using everybody.
See, sounds very beneficial.
Is to help you guys learn about our new decision tree flow sheet, which I will hand you guys at the end. It does have all the answers. So this flow sheet was designed to help us kind of walk through the steps of BOW program, know what we're testing, know what results we're looking for, so that it can be easier to come up with what the end result is going to be. So for our BOW program on day 1, we're gonna do that rectal exam. We have a patient scenario up on the board, so I'm just gonna kind of go through it with you really quickly. It's a 68-year-old T7, T9 spinal cord injury that has no trunk control. He's had compression on his cord for several years, and he's status post a fusion. Okay, so if we're on day 1 and we're going through that rectal exam, what is the first thing that we are now ordering? The medical team has decided that we're adding this to our spinal cord order set. What is the thing that we're ordering to help us look into what is going on with those bowels? Does anybody know? No, Abby does.
Being quiet.
And
look, y'all can come close. We have all
Yeah,
that
come
information.
closer. Sorry, this is meant to be interactive, and our answers are all right here.
So half of y'all can look at that one, half of y'all can look at me. So this is something, because we get in report, patients have had a bowel movement, and oftentimes they have not had either a significant bowel movement or a very small bowel movement. So this is something that we are ordering to make sure that they have had the appropriate bowel cleansing, so that we're not starting with them being impacted, constipated, or those kinds of things. So what are we gonna order for these patients?
What's a KUB?
That's it.
That's it.
That is an abdominal x-ray, kidneys, ureter, bladder, but it also gets in the colon and everything to see if you have extra air, stool, all that in your colon. So a lot of times those patients do have a good bit of stool in there, and that's KUB is gonna let us know
Is it
that.
ultrasound?
X-ray.
X-ray.
It'll help us visualize.
Okay.
Right. Okay, so we got the KUB ordered. So going into the bowel program with that patient presentation on the board, what would be the position that we would do the rectal exam in? No trunk control, would you say? Great, okay. What side, right or left?
Left.
Why?
I'm not sure actually. Is it because of the
But
anatomy of
that's
the
what we
large
do.
intestine?
Correct. It is,
Yeah.
it's the anatomy of the large intestines, that is where the end of it empties.
It also puts less pressure on the inferior vena cava, makes it less likely the patient will pass out.
I'm pregnant women also.
Yeah.
All right, so going down in the flow, what would be the next thing? So we're looking at some of the blue items. What else would we be checking for or assessing?
DAP?
We're gonna get there.
Okay, at this point, we have the patient sidelined. We're gonna insert our glove lubricated finger. What's gonna be the first thing we're gonna find out?
Check for impaction.
Check for impaction.
Okay, and what are we gonna do if we realize, man, we're in there and we feel stool?
You're gonna remove it.
Okay. Remove stool if present. Okay, while we're in there, what other item are we gonna be assessing? We're in the rectal cavity, what else are we assessing? As soon as we put our finger in there, what are we feeling?
Not for the wing, but for the,
We're getting there, one,
the, what is it called, where they squeeze it.
okay, even a little bit more
Not quite.
basic,
Resting?
resting tone. Okay, what I have three different conditions on the board that resting tone could present like. So we've got normal, which would be you and I, right?
Spastic.
What other?
And flaccid.
What does spastic mean?
Difficult to move it. If it's
Overactive.
Okay.
Yeah.
Okay, and flaccid, a lower tone, right? So with that patient presentation, T7, T9, it could go either way. Jessica and I, our example, we're thinking that's more of an upper motor neuron, so perhaps more of a spastic presentation, a hypertonicity. When I go in, I'm feeling tightness, okay? For the next one, going down the list, what else are we gonna assess while we're in there?
So now you can.
We're gonna get there for
Contraction.
reflex.
Anal contraction.
Yes.
Yeah.
Okay.
So, which one
Yes,
are you pulling?
that'll be the second one. I'm gonna pull the sensory one first, just because I like to keep it in order. So we're gonna look at sensory.
Deep anal pressure. And then what's the motor one?
Contraction.
Contraction, okay. Deep anal pressure. We got our finger in there. What is the question we're gonna ask them if we're asking for sensory?
Can you feel something?
Can you feel?
my finger?
Correct. Nope.
Yes.
Can you squeeze my
Next.
Yeah, it's next.
Motor. Can you squeeze my
Good
finger?
job.
Very good. Not pull, squeeze.
So if they can feel you, if they say yes, they can feel you, what are these two questions, what are we trying to get out of those questions?
How much control and sensation do they have? So calm, what's the indication? And level.
So yeah, it would more be, not necessarily level, but
Reflex?
Completing.
Complete versus incomplete. So if they can feel you,
That's complete.
we're incomplete, right? Okay? If they can squeeze, they're also incomplete, right? So either way, they can do either of these, they are incomplete. Okay? If they cannot, what does it mean?
Complete.
Possibly complete. At this stage of the game, it's possible that they're complete. Okay, so we've got all that. So we can get all those things done by getting our finger in there. We can assess for impaction, resting tone, sensory, and motor. So then that brings us to the next thing, which is reflex testing. What is that reflex test that we have taught you guys that can assess for the bowel program? Not yet.
The wing?
The wink.
assess the anal wing.
Can anybody tell us what is involved in assessing the anal wink? What do we have to do?
Like a little stretch, right? Or,
So we're doing something here. This is our rectum.
You're gonna take something, kinda, isn't it, and just kinda like rub or something?
You can potentially rub, but what we're
Are
looking
you
for
pin-
here is the
Yeah, there you go.
pinprick.
Little pinprick, safety pin, right? Sanitize the safety pin, little pinprick right around the sphincter, and I'm looking for a wink,
gentle-
a pucker, okay, a pucker in the rectum,
So just a gentle prick. You don't wanna draw blood.
right? So if I have a pucker, if I have a positive result and I see a little pucker, what is that telling me?
The reflex is intact.
Reflex is intact, and I am gonna be on a reflexive bowel program. My reflex is intact, so I would benefit from what type of program? What's left on the board here?
Manual evacuation.
I have the
I'm sorry,
reflex.
the ditch stem.
So if I have the reflex, I'm gonna benefit from dig stem. And dig stem means what?
Digital stimulation. What do you ask?
What is it?
Something comes out.
You're stimulating the muscles to move the bowels down and out.
Okay, how long are we doing that for?
Well, like it's 30 seconds.
30 to 45
Yeah.
seconds?
Or depending on how long your patient tolerates it.
Good,
Every 5 to 10 minutes.
every 5 to 10 minutes until you get the
Until
stool
it's
out.
empty.
Okay. If
So
I
you go
don't,
in and stay in there for
30 seconds, to 30 to 45
Stick
seconds.
it, your finger goes all the way in there, and you do that gentle circular motion.
And it's
For
usually
30
very
seconds.
uncomfortable for the patient, especially if they can feel. So,
And then if you get no results after 5 minutes, you repeat that same process.
right, you keep repeating it until basically it's empty. Then they are empty.
And the
Right.
beginning part of that is they're having a meal, 30 minutes later, getting the suppository, and about 20 to 30 minutes later, then we're starting the actual process of
Stimulation.
stimulation.
if I poke the skin around the anus with the pin and I get zero result, I don't see anything, what does that mean? Areflexive? And what type of program would that indicate?
The manual evacuation.
Okay. And my patient is in left sideline, right? I can do that in left sideline. I need to remove the stool that's present. If I get to the point therapy where my transfers are improved, I'm demonstrating trunk control. Now we're max assist and we're telling nursing, okay, we're good to get on the commode. Can I do manual evacuation on the commode?
Yes, please.
Yes, right? It would be better, more anatomical. Gravity's gonna help me eliminate that. Okay, so if this patient's, his presentation to us right now does not seem very acute in nature. It said he had compression on the cord times several years. So if my injury is not very acute in nature, I'm not necessarily gonna do the next test, which is the bulbar cavernosus. I'm only gonna do that test if the injury is acute. Like Jessica used examples earlier, a gunshot wound, maybe we had a patient that fell off of a bull. You know, something very acute that happened in the last week. Then I would wanna do this more invasive test. And we talked about this test. We wanna save it for only those injuries that are more acute in nature. And if the anal wink is negative, I wanna consider doing this test. Do you guys remember what this one was? Bulbar cavernosus, Abby?
That one is not down here.
That one,
It's a little bit more invasive one. Chelsea, would you like to chime in?
Test for spinal shock.
Okay, so I'm testing for spinal shock. I wanna
That
see
one
if
is
these reflexes are still turned off, or maybe they're turned on. So Jessica, can tell us what the bulbar cavernosus is? How do we do that?
So, if we really think they're in spinal shock, we are gonna have the patient sideline, our finger is gonna be in their rectum, okay? If they have a catheter, we're gonna do a gentle tug on the catheter to see if we can elicit a little squeeze response around our finger, okay? So that is what we're looking for. That would mean the patient is no longer in shock. So, they have a reflex. We can use a reflexive program to help that patient evacuate their contents of the bowel. However, if they don't have a catheter, we're gonna do a squeeze on the glans penis or a squeeze on the clitoris. Yes, they are very difficult conversation to have. Patients are kind of a little bit uncomfortable with that. Even you guys would be uncomfortable with saying, hey, I'm gonna have to do this, but as part of our assessment, it's necessary for the patient for us to get the information we need. So if we do that and there's no response, we have a negative response, patient could still be in spinal shock. So we're gonna do this areflexive program. So are we done there, or do we might need to reassess this?
It would need to be reassessed.
So for anybody who has a negative anal wink and a negative response to that BCR, we need to be reassessing that probably on a daily basis. Or if when you're treating a patient and you start noticing a little bit more maybe tone or different responses, then we definitely need to do those reflex tests again, because we potentially could be changing our program. It's just very important. We'll get with the doctor if we do start seeing results. Get with the doctor, change the program, and then get them on a different path, and educate them that way. So.
And I would say, like Jessica said, 80% of our patients are more usually not in spinal shock to where we would need to test this. So you just need to use it when the clinical presentation is suspect of spinal shock, a more acute injury, or perhaps a negative anal wink. So for the anal wink too, just remember, we had a patient just recently on Friday, we assessed him, anal wink was negative. 2 days later on Sunday, we're reassessing and the anal wink is now positive. So we were on a manual evacuation program on Friday. When that result became positive, it was imperative we let nursing know, let the physician know, and we changed the program to digital simulation to help them progress in their bowel program, help them become more independent and get them on the right track with what we selected. So just continue to reassess. Anybody that has rectal access can assess anal wink. Whether it's me as PT, maybe I'm going back to change them. If I'm back there, I can go ahead and reassess that, okay, and check on that result. Do y'all have any questions?
Some patients coming in, they are very constipated when they come in. That area has been stretched out so much that they may not elicit a response when they really could potentially have reflexes. So those are some things to consider. They may have some swelling that's keeping us from getting the response we need, so that's why it's just important to reassess. So, questions? Everybody get a little bit more confident, comfortable about some of this stuff? We do have these orange papers. They are a guide, a decision tree, just to kind of help. It's more for nurses, therapists that are actually doing it, but everyone is welcome to the information.
Sure, and the board is actually a nice flow too of basically what we have here. It's just an outline. It kind of takes you through the steps, but also it indicates what your results mean in case you need to just double check yourself.
All right, thank you guys.
Thank you.
So the goal for today is to get back to the basics. It's about learning what neurogenic bowel and bladder dysfunction is and how a spinal cord injury really impacts our patients' abilities to manage those things independently. So in the other rooms, you're really learning the what our policies are, what our patients have to do, basically what is expected of us. This room is all about why. Why are we doing it? Why do we have to do it? And why is it so important? So I hope when y'all walk out of here, you feel like you understand neurogenic bowel and bladder dysfunction better than when you walked in. So just as a recap, as we know, most of the time, our upper motor neuron injuries like T10, T11 and up tend to present with a more reflexive presentation. Bowel and bladder is governed a little bit by the somatic, the enteric nervous system, so it can operate a little bit separately. So we do the reflex testing like y'all learned in the room right before this. But normally with our reflexive presentations, we're gonna see increased tone or tightness in the muscles. We're gonna see increased spasticity at the levels below the injury. And we're gonna have a reliance on reflex-mediated activity, right? These sacral reflex arcs, or the reflex arcs of the spinal cord, are housed more in the sacral region of the spine. So when we have damage in the thoracic and cervical region, the sacral part is intact, right? Those reflex arcs are intact. We just lose a little bit of the ability for the brain and those reflex arcs to communicate. So we have to find different ways to engage those reflexes in order to utilize them to our patients' benefit. For these patients, their sphincters, both anal and urethral, are gonna stay pretty tightly shut at rest, and they're really unable to relax them. So these patients are at a high risk for urinary retention, constipation, fecal impaction. All those things increase the risk for autonomic dysreflexia in these patients. We're also gonna have increased tightness in the bowel and bladder walls, which really diminishes the potential for storage down the line. On the other side, our areflexive patients, usually more lower motor neuron, are gonna have more decreased tone, right? A more hypertonic state below the level of their injury. We're gonna have more flaccid musculature, both in like the inside the body and our skeletal muscle as well. These patients are not gonna be able to utilize reflexes because the damage is occurring where the reflex arcs are actually housed. So it's not so much a communication issue at this point, it's a damage to those structures. If your central AC goes out at your house, you can't fix it by buying a new thermostat. You can't work around the damaged area to get reflexes because the reflexes are what are damaged. For these patients, their sphincters are gonna stay partially to fully open at rest and be unable to contract or close. So these patients are gonna have more frequent incontinence and accidents as opposed to the constipation and the retention. These patients also have increased relaxation in the bowel and bladder walls, increased flaccidity, so they have almost an uninhibited storage capacity, which is also a problem. So when you take a bite of food, you chew it up, swallow it. We have a set of stretch detectors in the esophagus, right up here at the top, that detect the presence of that bolus, and they send a signal to the brain to initiate the digestive reflex or peristalsis. So peristalsis is just the coordinated contraction and relaxation of the muscles down the esophagus to push the food down towards the stomach. Once it gets into the stomach, that's where digestion occurs, right? Important nutrients are reabsorbed back into the body, everything else is formed into waste. We have a second set of stretch detectors in the stomach itself, that when those baroreceptors detect that stretch, they send information to the brain to then send a signal down to the intestines to begin that peristaltic activity. So that is what helps us move food from here all the way through this really complex maze of intestines down and out of the body. Once the food makes it, or the stool makes its way into the descending colon, we have a third set of stretch receptors that will sense the presence of stool, and they'll actually send info to the sacral segment of the cord, the reflex arc, to initiate the defecation reflex. The defecation reflex is what is responsible for relaxing this internal anal sphincter and kind of contracting the wall of the colon to push the stool out. The internal anal sphincter is completely involuntary. It's made up of smooth muscle. It's really just a continuation of the descending colon. We have no control over our internal anal sphincter. The only way we can release stool from the colon is through reflex activity, okay? Once the stool enters into the rectum, then that sends information to our cortex to let us know, hey, it's time, go find a bathroom, and then we're able to voluntarily open our external anal sphincter because it's made up of skeletal voluntary muscle. Bladder's pretty similar, makes its way down the esophagus, the liquid gets pushed into the kidneys where filtration occurs, right? Toxins are flushed out, it creates urea, water content gets added to create urine, that then flows down into the bladder where storage occurs, okay? In a healthy individual, at about 400 to 500 cc's, you're gonna get your first signal to the brain to say, it's not really urgent, but just so you know your bladder's filling up, you might not wanna get too far from a bathroom. At about 1,000 to 1,200 cc's, that's when you're in the grocery store and you start crossing your legs until the sensation passes because you're like in the middle of the produce aisle and you have a full buggy. When you get to about 1,500, you can no longer ignore it. That's about the time where you are running to find the bathroom and you sit and you pee for a good decent amount of time. So the stretch that gets detected in the bladder, it sends two sets of signals. So it's gonna send one set of signals up to the brain, to the pontine micturition center, which is responsible for contracting the bladder in response and opening or relaxing the internal urethral sphincter. So that's how we get urine out of the bladder. It also sends signals down to the sacral micturition center in the cord to send one good contraction to the bladder to help fully empty it. So it sends signals both directions, and then both of those reflex centers work together in a synergistic fashion in order to fully empty the bladder. At that point, the internal urethral sphincter opens, urine flows out, and then we consciously relax the external sphincter in order to completely empty the urine from our urethral canal, whatever it's called. So you can see how important the spinal cord is in coordinating everything that has to do with bowel and bladder functioning, and you can see why damage to the cord can lend itself to a pretty disrupted system here. So for demonstration purposes, this is our descending colon, okay? The colon here, internal anal sphincter, and then the beads inside of here are the stool, okay? So a patient with a reflexive bowel, this is what it's gonna be like all the time, right? Tight, contracted, no matter how much stool is in there, you can jump up and down, you can stand on your head, it's not gonna come out because this is not gonna open. right? So what do we do to help our patients with reflexive bowels have bowel movement? Dish stem. Okay, so dish stem is our way of, as Elena said, going through the back door and putting pressure on the pudendal nerve to make it come out like soft serve. That it really truly is what it is. So when we go in and do dish stem, right, we manually open the external sphincter with our finger, and then when you put that pressure on the rectal wall for 30 seconds, the sensory fibers in there, they don't really care what it is. If they detect the presence of something, they're gonna send the signal to the cord. So when we trick the body into thinking stool has already descended into the rectum, it sends a signal to the sacral cord to say, hey, keep that sphincter open, we're still going. So at that point, anybody who's done dish stem can probably say there's a distinct moment where you feel, it almost feels like an exhale. So everything's super tight, and then everything just goes, and the internal sphincter opens, and the rectal wall relaxes, and the patient is able to defecate. So when you do it, right, you do 30 seconds of dish stem, you open that sphincter, you're gonna get a little bit of stool out. You're not gonna get it all in one try because that sphincter wants to be closed. It's going to close right back up. So we wait 5 minutes, we let more stool descend, we go back in, we do another round. We get more stool out. And you keep doing that over and over again until you have fully emptied the rectum. Our patients with areflexive bowels have the opposite problem, right? So their sphincter's staying open, but we can't contract the rectal wall to propel the stool out. So that's why we have to go in and do manual evacuation, okay? A consistency thing here. If we didn't worry about the consistency of the stool for our patients, and they just had loose, small, not well-formed bowel movements, every time they went upright, they would have a bowel movement. So our patients with areflexive bowels, because they have such an open sphincter, we really try to bulk up their stool with fiber, Metamucil, whatever we can to make their stool more firm and formed so it'll stay in that rectal canal or the anal canal until we have a chance to get to the bathroom and make it come out. The bladder is more about storage capacity, right? So for demonstration purposes, this little water balloon is gonna be our spastic bladder, and this bigger balloon is gonna be our flaccid bladder. Okay, a healthy bladder would fall somewhere in between those. So for a spastic bladder, that's about as much as I can get before I face a lot of resistance, okay? This would probably be an estimate about 800 to 900 cc's of urine, okay? A lot of times our patients will, they'll have a little, maybe slight spasm or something, and they might leak out a little bit of urine and they think, I'm peeing. Or we look at it and we're like, yay, you're peeing, you're healed. But all they really let out, even if they let 300 cc's out, they've still got 500 to 600 cc's of urine in their bladder, and that's what it looks like. So the problem is, when that urine's in there, those stretch detectors, right? They detect that stretch. They try to send their signals up to the pontine center and the sacral center, but the message is not getting to the brain, right? We have damaged the cord, we have damaged the communication pathway there. The pontine micturition is arguably the more important of the two reflex centers because not only does it send a signal to contract, but it also sends the relaxation signal. It sends the signal to the internal sphincter to open and let urine out. So what's happening is we're not getting the message to the brain, so there's no signal coming back to relax the sphincter. The sacral micturition center, who's just responsible for squeezing, is just going off without a hitch. So these patients have urine in their bladder, they're getting a signal to squeeze and contract the bladder, but this is not opening. There are two possibilities here. This can either build up so much bladder pressure that this eventually explodes, or the bladder wall tears, or more likely, the urine is gonna take the path of least resistance right back up those ureters into the kidneys and reflux. That's called hydronephrosis, and it puts people on a transplant list. If we let it happen frequently, patients can lose functioning kidneys. It is a one-way valve. It is not designed to accept urine from the bladder, okay? So we have to stick to our voiding schedule, cathing, timed voiding, reflex voiding, whatever, to make sure that they're emptying their bladder so that when those uninhibited bladder spasms happen, there's no fluid in there to reflux. So when your patient is like, please don't cath me, I really want to keep trying to pee on my own, we support them and we say that's great and we want you to heal, but we have to make sure we don't damage your kidneys in the process. We'll give you opportunities, but if you're holding a whole bunch of residual volume in your bladder, we have to empty it. The areflexive bladder is going to have the opposite problem, right? It's going to have uninhibited
filling, right? There's no tone in the bladder wall to stop this from happening. It's just gonna stretch and stretch and stretch. Now, if you're someone with a tiny bladder who your family always gets mad because you make them pull over 10 times on a road trip to pee, you might think, oh, this would be kind of nice. It's actually not. It's quite terrible for your bladder. When they have bladders this full, there's a bunch of things that can happen. First, they're gonna spill. The bladder's not designed to hold, this could be like 2,400 cc's. They're gonna leak a little bit out around the sphincter, and what happens is that tricks us into thinking the patient's peeing and not worrying about it, but really they're just holding this gunky old, because the spilling is gonna be the new bladder, or the new urine. And they're just gonna have this old bacteria-infested urine sitting in their bladder for potentially days, okay? The other problem is that when we do finally empty this is what their bladder looks like now, as opposed to what it looked like when I started, okay? And it's not dramatic, this is what happens. The bladder is made up of some striated muscle that has spindles in the fiber that when it is overstretched, it damages those spindles. It'll tear them apart from each other. The way contraction works, right, is spindles drawing in on each other. If you've ever had a baby and you got stretch marks on your stomach, you know that those stretch marks did not go away when the baby was born because it was damaged. The same thing happens to the bladder. We can have patients over-distend their bladder over and over again, overstretch their bladder, destroy those muscle fibers, and then they heal from their spinal cord injury, but they can never fully contract their bladder ever again. They always have urinary retention, they always have high residuals, and they're at a high risk for UTIs. Same thing here, if we're refluxing in the kidneys, they may recover from their cord injury, but now their kidneys are damaged, and there's nothing we can do about that, okay? So it's really, really important that y'all understand that, and I really hope you remember this visual. If you do have a patient and they're trying to talk you out of sticking to their bladder schedule because it's embarrassing or it's uncomfortable or they just don't want to do it, and remember that if you make the decision in that moment to not prioritize this, you personally could be contributing to that patient damaging structures that they will not be able to recover from. They don't understand that, it's our job to understand that. Okay, any questions? All right, that's it.
Spinal cord injury. Spinal cord injury. All right, stop. Collaborate and listen. OTs are back with a brand new edition. So your injuries help on your spine, your bowel may be reflexive, and that's just fine. So you're dealing with constipation, try some digital stimulation to the extreme. It might be a little painful. Just make sure you're going at the right angle. We know how to help you fix that problem. When issues come up, we'll help you solve them. This ain't a horror story. You might need a suppository. Hold it against the rectal wall and head to the bathroom stall. 20 minutes, make it melt like a candle. Don't worry, this ain't nothing we can't handle. Put a finger in the back door, make you wanna poo more. Yeah. Put a little pressure on the pudendal nerve, make it come out like soft serve. Move your fingers in circles, big and slow. Repeat for 30 seconds and stool will flow. Wait 5 minutes and repeat till you're done. Don't quit early or you'll have accidents, son. Gotta stick to the schedule every day to keep it regular, and that's okay. Take notes as you need to. We'll help you stay regular with your poo. Rehab team will help you with independence and come to a place of self-acceptance.
If your injury's in your lumbar spine, you may not have reflexes, and that's also fine. You might have to do a different bowel program, but we'll still help you meet all your needs. Now you may not be able to do stimulation, 'cause your reflexes have all gone away. So you'll get yourself onto the toilet seat 30 minutes after you leave. Well, gravity works to pull it all down. Peristalsis helps to push it all through. But you'll need to do a little work of your own to evacuate all of that poo. Some folks use a padded bedside commode if they've got a painful wound on their tush. It's better to be sitting up on a seat and use those pelvic floor muscles to push. Let the stool descend. Let constipation end. Let the whole world know that today is a day of continence. Let the weak be strong. Let the poop be gone. Roll that fear away. You can go on vacay. It's Independence Day. So you've got trouble peeing. I heard your cord's a little damaged. And your goal is to get back on your feet. Just a man and his will to survive.
Dun, 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 dun.
So many times it happens too fast. Before you know it, your bladder's leaking.
Dribble, dribble.
You're gonna have to learn a new way to avoid, to keep from recurrent UTIs.
Antibodies coming your way.
It's the eye of the catheter into the urethral hole, and it goes straight into your bladder. And the flow of the urine into the bag, and we want you to only have a small residual. 4 to 6 hours at a time to keep volume low in your bladder.
Keep them numbers low.
How much you get out every time you void, and what you leave behind, it really matters.
We love our
It's
patients.
the eye of the catheter into the urethral hole, and it goes straight into your bladder. And the flow of the urine into the bag, and we want you to only have a small residual.